understanding common complications we will see. So one day, as my thoughts were wandering, which is fairly often for me, I thought of this picture of us flying through our day and just kind of hoping that the pills and sometimes the needles that we're dropping off to our patients on just to be able to survive our day to day. And I because I thought of this, I didn't do this. I asked AI to make it, and they did a pretty dang good job. But just kind of a crop duster, and that's on some of our low points of our days. Of this kind of feels like what we do, mostly out of necessity, whether it's for time or unfortunately a business model, of course. Obviously this is a hyperbole of exaggerating what we do, but we hope to see some benefit in the weeks to months, later at our next insurance approved flyby for follow-up. So this presentation, I wrote it, the meaning for it is to give you all a PM&R specific view on the most common devices we're most likely to see, or we're most likely to prescribe, or some of us will be implanting some of these directly during our inpatient outpatient visits. Also, knowing of these devices, that they can cause some complications in your daily work, even if you're not the primary provider for these devices. So, a brief overview of the impact of chronic pain and spasticity, and some of these details were on my grand rounds last year, but about 1 in 5 U.S. adults experience some form of chronic pain, and about 1 in 14, or approximately 7%, experience what's called high impact chronic pain, defined as having pain on most days, or at least on most days at least, or sometimes every day during the last 3 months, that limit their life or work activities. Okay, and per the CDC reports, 2011, economic costs of just chronic pain, okay, were between 560 and about $635 billion in direct medical costs, lost productivity, and disability costs. And on the spasticity side, that affects approximately 35% of stroke patients, 50% of TBI, 40% of SCI, greater than 90% of cerebral palsy, and a wide range of patients with multiple sclerosis, kind of 37 to 80% or so. So what is our role as physiatrists in managing chronic pain and other impairments? Well, of course, interdisciplinary care. All of us rotating through sheltering arms, anyone on an inpatient unit, are very aware of the IDT meetings, right? Collaborating with other providers, psychologists, neurologists, surgeons. Anytime we're in the outpatient setting, obviously we're going to be bringing in whoever needs to see our patients. All right, interventional pain management, whether it's ourselves within our department, or if you're not available directly with an interventional pain, obviously they can come in and do injections, trigger points, implanted devices, stuff like that. Non-surgical treatment, we are the bosses of this one. PTOT, doing some med management. We are needing to do exercise prescription for a lot of our patients, CBT, neuromodulation techniques. And then of course prevention of secondary complications. All right, we're preventing any further musculoskeletal impairments, deconditioning of our patients, allowing them to heal themselves, kind of the way that we're taught as DO. So I bring this into a lot of my daily life is helping the patient be in a better position to help themselves continue with their health, rather than just saying, here's a pill. Right? It's a multi-step process and a journey, not a sprint. So implantable devices have seen significant advancements and increased usages over the recent years for many reasons. So rising demand, we got aging population, okay, more prevalent chronic pain conditions, increased demand for effective treatments, improved outcomes. We're seeing that with these advances in technology, we're seeing that not only is it just it's not a systemic medication that can hopefully target whatever your pain is, but we can actually specifically say, here's your target pain. We can, EMG is not breaking technology, but it helps combining with that and other imaging and other testing. We can focus down on the exact target and improve patient outcomes. Miniaturization, right? We've got all kinds of technology now to make the smallest devices, and it makes it a lot easier and discreet. Think of what it used to be like to need oxygen. You had to carry around that big, scuba tank on a roller. Now you can just carry it around in a little backpack or a little, smaller than a lunchbox or something. Wireless capabilities is another one. Neural stimulation. We'll go over that later. Tailoring therapies, and then combination therapies, obviously what we talked about already and kind of what we do in PM&R. And then the key reasons for the increased use of implanted devices, it's well known that traditional therapies, sometimes it's not a one-time or one size fits all for our patients. Despite advances in pharmacotherapy and non-invasive interventions, we are seeing that that's why implanted devices are being used more. Technology is not, like I said, it's already it's a big part of why these are advancing. Patient outcomes, durability and longevity. Modern implants are designed to last for several years. For instance, some of the spinal cord stimulators, the batteries are lasting for 10 years plus. Leads for sometimes longer than that. So all you need to do is replace the battery after 10, 12 years when it stops working as effectively, and you don't have to redo the entire thing, especially if it's working very well. And then patient preference. Many patients prefer the long-term benefit and convenience of an implantable device over, ongoing medication management and having to get the refills and, all the 3 or 4 steps each month that they have to go through with some of those. And us as physiatrists, we need to know about the options, the indications, and appropriate consults that we can place in order to provide the best care for our patients. Now, on the other hand, we do see an increased risk of injury and device-related damaging events, as according to the study by Fitzgibbon et al. In 2016. They narrowed down several thousand down to 148 medicine device-related claims that obviously met within their criteria between 1990 and later. Obviously, there's thousands more than that, but the inclusion criteria obviously were quite narrow. But the device-related damaging events, medication administration events, infections, hematomas, retained catheter fragments is a big problem. Any kind of direct cord or cardiac trauma, the device just not being implanted correctly or programmed correctly. Some were user error, some were the actual device. But with that, they noticed that, or the system, I should say, with the most use was from the 1990s on, where the implantable drug delivery systems, in the future it'll be called the IDDS. That was about 64% of their claims, and then spinal cord stimulators were the next most popular, I guess, or most frequent claims at 29%. And severity of injury was greater in the IDDS maintenance or management claims, leading to 56% death or severe permanent injury. That included medication administration errors, which was about 32% of the total claims. Spinal cord injury, mostly due to delayed recognition of the granuloma formation, which is the next most severe, about 22%. And then surgical, things related to the surgery around the device, infections, inadequate pain relief, not a severe injury, obviously, they don't get adequate pain relief, but definitely a problem for the patients. Trauma to the cord or retained catheter fragments, all numbers are there included. So the main implantable devices, and I'm not talking about specifically surgical instrumentation, right? You see the fusion stuff, we've seen X-rays, MRIs, all that kind of stuff. I'm talking about a device specifically implanted that does something for the patient specifically, rather than just, okay, surgery and then implanted, and then now we're out and we're never going to touch it again until it breaks. But this is, something where it's actively doing something for our patient. Spinal cord stimulator, IEDS that we talked about, peripheral nerve stimulation, dorsal root ganglion stimulators, interspinous spacers, and sacral neuromodulation. So I'll start off with the spinal cord stim. Approximately 1 million SCS placements from 2000 to 2019. Mechanism of action, well, it's still being investigated, right? SCS is kind of like an internal TENS unit in very basic layman's terms, but instead of going through subcutaneously and doing it that way, they actually block and interrupt the signals in the dorsal column of the spinal cord. Some of the proposed theories include like the gate control theory, descending pain modulation, or the direct inhibition of nociceptive neurons. While these are important to the pain minds and potentially my future, and I will know about that future about 1 week from today, but nobody's counting. It is more in depth than I had in mind for this presentation, so we won't worry about those things right now. All right, common indications for spinal cord stim. It's primarily for the management of chronic intractable pain. All right, so things like CRPS, failed back surgery syndrome, which is also known as post-laminectomy pain syndrome. You can use it in diabetic neuropathy as well, and some other peripheral neuropathies if it's a large enough area. Things to consider, though, with spinal cord stimulator. It's not just a quick little implant. It's very long. I got a timeline next, so I'll go over that. But there's things that you have to go through a trial period. You have to go through a bunch of different tests, and then also things to consider is in the future we've got about 98% of patients who with spinal cord stimulators need an MRI, at least one MRI, 10 years after that spinal cord stimulator is implanted. So knowing that only some implants are MRI compatible or even MRI safe in general. For instance, like the Medtronic brand, from their website, it says MRI, the SureScan MRI technology allows for full body MRI scans under specific conditions. So you have to decrease the power of the MRI, the amount of time, the size of the body parting, and all these conditions. And then Boston Scientific has one as well, with specific the actual implantable device and the leads that go in. You have to have a very specific combination of their products to allow you to be MRI conditional, similar to the Medtronic. So yeah, knowing this again, if they can only get a CT and they need certain evaluation from another consultant, obviously, that's going to be limiting. So here's the timeline for spinal cord stimulator, just for people who may or may not be interacting with it in the future, or referring people. Just it's not a couple of days or weeks thing, right? The initial consult with a pain management specialist to evaluate even if spinal cord stimulator is appropriate or suitable option. Obviously, weeks to months waiting for that appointment. Sometimes they unfortunately are just really busy. Diagnostic testing, if not already completed, additional tests need to be performed. Also waiting for weeks, possibly even months, depending on the location of the patient. In addition to that, they also need a psych evaluation. Insurance companies are requiring this psych eval prior to approval of the final implant. Insurance approval, days to weeks, sometimes never, unfortunately. The actual implantation procedure, like I said, the trial implant, you test it for about a week, where you determine the efficacy of the actual implant. It requires at minimum 50% or greater pain relief, later removed in office, and then they have to wait a couple of weeks between that, the trial and the permanent implant, in order to get the go through the actual full procedure under general anesthesia. And then, a couple weeks after that, and then recovery and adjustment period after getting the spinal cord implant, which again, 6 to 9 months, sometimes a year. This is not a quick turnaround for the most part. then just because the implant is there doesn't necessarily mean that it will, one, it's in the right location, two, it will automatically work. You need to adjust each of the leads to different frequency, all that kind of stuff. And this could take months of tailoring very specific programming needs for the patient. So not only time to get it, but also time once it's in to figure out what's actually working for the patient. Basic components, implantable pulse generator and the battery, leads, or the electrodes. There are cylindrical electrodes, just like the one shown up here. They have multiple contacts. That way you can kind of provide more targeted stimulation and increase or decrease those leads directly. And then ones that are only implanted by neurosurgeons are the paddle type electrodes, longer, flatter, kind of leaf shaped, if you will, that kind of more wrap around the spinal cord rather than just sit on top of it. And that's if there's other procedures and surgeries that need to happen as well, like laminectomy or something, just so the leads aren't moving around as much. Remote control, charger and base station, all those kind of things. And then it just kind of gives a basic. The pulse generator is implanted typically in a little flesh pocket down here in the by the hip posteriorly, and the leads are tunneled underneath the skin. Enters into the kind of upper lumbar, lower thoracic region, and then goes as high as T7, T8 is pretty typical, but that's kind of what it looks like. You can see them, they're right here on the posterior column, but then we'll talk about the dorsal root ganglion simulators as well, but you just kind of see the difference between this is directly on the spinal cord versus this is going to the side. So potential complications that you need to know of, lead migration, shifting from its original position, affecting pain relief, right? So if we're targeting nerve roots that are at a certain level and then it moves away, it's no longer obviously targeting those. So we need to be aware that if we see something like this on an x-ray and somebody says, hey, my chronic pain's back and it's not working, well, we have a very obvious reason for that. Lead fractures, they can break and may require replacement. And a personal story, I met a patient who had a 4-lead spinal cord stimulator, 2 going caudally and 2 going cephalad. I think I pointed the wrong way for that, but 2 going up, 2 going down from the implant site, and 3 of the 4 had broken because she was in a pretty severe car accident, and none of them could be removed because of where they were broken. And one had actually, the one going towards her head actually, she called it done a U-turn. It actually had bent downwards and was now kind of going, inferiorly. The lead had fractured down where it was entering the spine. So you got the entire lead going up into her spine, and now it was curving downwards and starting to, kind of move the entire lead inside her, causing pretty severe pain. And just, it was quite shocking to see just how bad it could get. Quite extreme, obviously, but yeah, it does happen. Battery depletion, well, you just need to replace the battery. Hardware infection, around the implantation site or up into the spinal cord, which would be kind of worst case scenario, because that can cause significant problems on its own. Things like bleeding, dural puncture, neurological injury. Obviously, with any spinal procedure, those can happen. And one study I noticed that came out this year, actually, by Song et al. At investigated lead migration and trial spinal cord stimulator. So over 3 years from 2020 to 2023, they followed 27 patients who had the trial stimulator implanted, and the pre and post flexion x-rays taken immediately after implantation, and then later 1 or 2 days after implantation, set the distance of lead migration, and if it was clinically significant, it was greater than 10 millimeters of overall movement, or 1 centimeter. Essentially, they were saying that all of the leads that had moved, all of the migrations were caught at, except for one of the trials, and it showed clinically significant lead migration in 20 of the 27 patients that this one study followed. and noted that, risk factors included increased BMI, certain anchoring techniques. Obviously, that's not part of the patient's problem, but 74% of patients having lead migration, that's a very significant amount of patients. So that's a pretty high risk. That's not spinal cord stimulators. Now, something that we're all pretty aware of, at least in this room, because just a couple of weeks ago we had 2 hours in one morning of lectures on baclofen pumps. But the intrathecal drug delivery systems, or IDDS, they're referred to as pain pump or baclofen pump. It's embedded into the patient's body, delivers small time doses of medication via intrathecal catheter placed in the CSF. Now, this allows for high CSF concentrations and relatively low systemic circulation, decreasing most of the adverse effects of the medication, but comparatively to taking it orally. They're mainly used for management of chronic severe pain or spasticity that is refractory to other treatment modalities. And I was surprised to see that only 3 medications are FDA approved for the IDDS. That's going to be morphine, ziconotide, and baclofen. But there are plenty of other opioids and local anesthetics commonly used. So again, we shall be very aware of this. Here's the actual pump, the reservoir, fill it in the middle, the access port there, and the catheter port there. The reservoir is implanted somewhere in the patient's body that's easily accessible, and then the catheter is placed into the intrathecal space, and then there's some form of an external controller. So common indications that we know for this is going to be cancer pain, particularly advanced stage cancer, and bone metastases are very painful for most patients. In non-cancer pain, right, chronic back pain, CRPS is another reason for it, other severe neuropathic pain conditions, and then, of course, spasticity, associated with conditions like spinal cord or multiple sclerosis. Considerations and limitations to know for our patients is going to be it's invasive, right? It's not just a small thing. It's not a medication, right? It's a full surgical implantation, and it's going into the spinal cord itself. So it is fairly invasive there. Dependency, patients can become reliant on this device for management of their symptoms. Initial cost and ongoing maintenance can be high just because you're having to purchase, or not purchase, but continue to refill the pump with medication and potentially future surgeries as well. And the bottom line, it's not a cure, right? This isn't curing people. This is masking their pain or their spasticity, but it doesn't address the underlying cause. So for withdrawal, right, any sudden reduction of the drug that's being delivered due to malfunction of the pump or catheter, an empty reservoir, or just programming errors can cause withdrawal. And as we know, any withdrawal from an opiate, you're going to see people with myalgias, diarrhea, nausea, vomiting, anxiety, pupillary dilation. They're just not going to feel very well at all. Just more intense than kind of from withdrawing from oral opiates. And then baclofen, we all know the acronym or the way to remember it: itchy, twitchy, and very quick to let everyone know that they're very uncomfortable. So you'll see agitation, insomnia, confusion, delusions, hallucinations, all that kind of stuff going through. And typically the treatment for this is, we've been over the baclofen withdrawal treatment several times recently, but both need emergency department evaluation, plus or minus ICU stay, depending on severity, and then PM&R resident or attending coming in to make sure that those are filled up. Next up is the peripheral nerve stimulators. Okay, and the main thing to compare this to is the spinal cord stimulator, where spinal cord is on the posterior column, and as we know, that's multiple levels, right? This the target area for PNS is a very specific nerve, because you implant it directly onto the nerve, versus spinal cord is going to be a large portion of the body, sometimes even multiple limbs. Indications, localized pain, obviously, versus larger pain. And then the benefits are that PNS are much less invasive, and the risk of complications are much, much lower. So indications we can use it for: CRPS, things like post-herpetic neuralgia, phantom limb pain. There's an asterisk there for a reason. So we'll get to that in a minute. Trigeminal neuralgia, and other peripheral or peripheral neuropathies or chronic regional pains. So we cannot legally talk about peripheral nerve stimulation without referring to our world-renowned team of physicians at the VA and VCU, including Dr. Lester, Rob Trainer, Doug Murphy, and then Dr. Brooke Trainer at VCU as well. And Dr. Lester continues to be among the upper echelons of the Sprint PNS system in terms of total number of implants, and leads the region, actually, or I believe it's actually the nation now in implants. Sprint themselves have over 31,000 total implants nationwide, and there are several other brands who are available out there. Just so happens that I have a lot of direct information about the Sprint system, so that's why it's on here. Dr. Lester herself has implanted several thousand in total between her commercial research and her own patients at the VA. And also, she's a great contact for anyone interested in doing research at the VA for kind of chronic pain stuff. So the slide here shows you an article by the listed doctors there on top: peripheral nerve stimulation for the management of acute and subacute post-amputation pain. Or this article, they had 16 veterans at the VA staff post lower extremity amputation who received peripheral nerve stimulation plus the standard medical therapy versus just standard medical therapy alone. The most significant results were the PNS group reported greater reductions in average phantom limb pain, residual limb pain, reduced daily opioid consumption, and after 3 months post-amputation follow-up, fewer participants total in the PNS receiving group who were taking fewer opioids. And then just really quick, the components. You have the implantable generator here, the lead, thin flexible wire coming down through this, and you can see it's some are longer, some shorter. Obviously, there's a little hook at the end, and this one allows you to not only place it, but also it gives a little bit of resistance, so it doesn't just pull out. Relatively easy. And then an external programmer. Current PNS devices, like I told you, there's Sprint, StimRouter, StimWave, and Nalu there. The main differences are that Sprint is temporary for 60 days. The rest of them are permanent with a trial there. So depending on your timing and your involvement as a physiatrist, you may not be involved in the temporary treatment or terminated treatments. However, some patients with permanent implants, as seen on the slide, you'll follow up, and you may see these in inpatient rehab or SNF setting, and a lot of times you'll see them in your outpatient as well. But you need to know about the device and any compatibility issues that you may run into, i.e., for the Sprint device, you may not see the device implanted at all. You may not even know about it unless the patient tells you about it. But if you do see it in the office and you need an MRI, well, you can just wait a couple more weeks until the device gets explanted and then give the MRI. Where these other ones, it's MRI conditional, right? You can do entire body up to 1.5 Tesla, head and extremity 1.5 and 3. So it's just, you have to know the device, so anytime you have this, make sure you know what it is, when it was implanted, all that kind of stuff, and then contact the rep or the company in order to know what you can do for your patient. Next one up, dorsal root ganglion or DRG stimulation. Okay, it's an emerging technology for managing chronic pain, different than the spinal cord stimulator just a little bit, but it can help with CRPS, diabetic neuropathy, post-laminectomy pain syndrome, or that failed back surgery syndrome, then some consideration for various neuropathic pain syndromes. Let's see, including pelvic pain, groin neuralgia, extremity pain. It kind of goes to a specific body part or nerve dermatome, nerve level. Very similar to the spinal cord stimulator, like I showed you in that other picture, where it gets implanted and goes externally into the sorry, not lumbar, into around the vertebrae, and then implanted, right next to the dorsal root ganglion there. So limitations is relatively new with limited long-term data. Still, this is not a cure, or my least favorite F word, fix. This does not fix patients, and high variability between patients themselves. And generally considered safe, it can have its complications like infection, lead migration, or hardware failure, painful paresthesias, right? So people, or dysesthesia, right? Unpleasant sensation or pain from the stimulation, or just a loss of efficacy. It no longer works, despite having worked in the past. And then MRI compatibility. Once again, the big question is, if they have this implanted device, can we get any kind of imaging? Well, always ask the patient, always contact the representative of the company. But you can see from Abbott's specific thing, if you couple it with the correct lead and the specific implantable generator, you can do a 1.5 Tesla head and extremity only MRI scan. But anyway, things like that, you just need to know that for your patients. So interspinous spacers is the next one up. So these are small devices implanted between the spinous processes of the vertebrae to increase the spinal canal space, thereby relieving pressure on the spinal cord and exiting nerves. Benefits, right? Minimally invasive, and has a few other advantages over like an open spinal surgical procedure. Much shorter procedure time. You can sometimes do it just under local anesthesia rather than general. There's very little muscle disruption, if any, limited blood loss, then less risk of nerve damage or cerebral or CSF leaks, simply because you're not entering those spaces. Now, this is from FloridaSurgeryConsultants.com, because I couldn't find a ton of great research out there. But of their patients who they looked at between a interspinous spacer and somebody who completed a spinal fusion, 100 patients in each leg, 86 out of 100 had successful outcome 2 years after surgery, whereas 77 out of 100 in the same time had successful outcomes from a spinal fusion. So a few extra, but it can, for the right patient, it can provide really good outcomes. So the major branches, you can kind of see, and I've got some pictures of it in the next one. I'll just show you now. So this one here is Coflex. It's a U-shaped device that goes in between this in the interspinous space and allows for some flexion and extension. Because that specific U shape, it can bend with the patient, in flexion and extension rather. And this is Vertiflex, which is the one I specifically have had several chances of helping out with those implants, especially through medical school. But the Coflex is a dynamic one where, again, it does allow some of that movement. It treats moderate to severe spinal stenosis. And then it's not as secure when bending, laterally rotating, and flexing all at the same time, because that can stress the spinous processes as well as the device, leading to the main complication of fracture there. Vertiflex, static, right? Mild to moderate spinal stenosis. So patients with major instability, significant scoliosis, or have had any other invasive spinal surgery, definitely not good candidates for that one. And then brand and device specific aside, these devices are usually MRI conditional. Few are compatible, simply because of the titanium alloy used. However, always, again, go to the rep or the device manufacturer and make sure. You can see, just like I said, an x-ray. You can see it there. So you may get somebody to say, hey, let's get an x-ray of you, and see some random X, like a Spider-Man symbol or something. You're like, what the heck is that? Now you know, and can at least understand what they have. But if you look here, right? This is in flexion, so flexion forward. It's nice and wide open, and as they extend, this is compressed rather than the nerve root exiting that foramen there. So you're going to keep that more open to prevent compression of that nerve, that exiting nerve. Next up is the sacral neuromodulation devices, or bladder stimulators, as some call it. Since 1997, over 300,000 people have received these. They're used to treat conditions like overactive bladder, urinary incontinence, and simply by sending mild electrical pulses through the sacral nerves, and that can help control that bladder function. The benefits, I've said a couple: improving bladder storage capacity, reducing urgency and frequency, facilitating bladder emptying, as well as reducing incontinence. And our purpose for kind of functional assessment in patients with bladder stimulators, we need to assess their lower extremity function, any changes in gait or balance or mobility related to the implant. And you'll see why in a second on the next slide, the picture of where it's at. Pelvic floor muscle strength, right? Evaluating the strength and coordination of pelvic floor muscles, as they can impact bladder function and continence. If you aren't directly involved in that evaluation, at least knowing who to consult if you do hear those complaints from the patient. Sensory functions, as well as pain management. If there's any pelvic floor disorders that cause pain. So potential risks and side effects. Infection at the implant site, lead migration, battery failure, pain at the implant site, which I mentioned previously, and then also change in bowel function, simply because it's as you press the drive the lead, the electrode through kind of the sacral area, sacral nerve root. Just the proximity with the bowels can cause some adverse effects there as well. Let's see. There are two main ones I wanted to show you. This one is the implant here with the lead going through the sacrum, so that's going to be one that's chargeable through the skin. And then this one is a separate one where it actually stimulates along the tibial nerve, and then another lead goes up into the bladder here, so they can sit like this for however long they need to, if it's for pain or whatever the case may be. But it's less invasive, but it does have it's I don't want to say fallen out of favor, but what I read was it's a lot less favored by patients nowadays rather than the truly implantable one. But it was one of the original ones because they could take the tibial nerve all the way up and then branch off and into the bladder relatively easily. And here's what you'll see on an X-ray. You can verify the implant is in the right spot, the electrode placement, and then potentially investigating with MRI if they are compatible with that. So in conclusion, our objectives, again, identifying the most used implants for our patients, indications and complications there. So as physiatrists, we need to focus on the functional outcomes. How do these devices improve patient function and overall quality of life? The role of rehabilitation, obviously, we need to emphasize to our patients that the importance of any therapy, PT, OT, and any other interventions to optimize their outcome. And in addition to these devices, these are, again, most of them are not fixes to the problem, just mask symptoms. And then interplay between medical and interventional management. Physiatrists often work collaboratively with pain specialists and any other surgeons as needed in order to provide the best options for our patients. So again, knowing who to contact in your local area to make sure that our patients are getting seen the way they need to, obviously going to be best for improving patient function and outcome. There's my references, and then any questions? Lucas.
What do you foresee as the future of this field as far as, what's coming down the pike as far as what you'd like to see?
The question was, what do I see this field in the future? What's coming down the pike, and what I would like to see? Okay. So, I mean, just improvement of the current devices is kind of the main, I think the main focus, making sure that we can, as we're mapping and we are providing that the specific programming for each patient, it's just going to get better and faster. The ones that I've been directly involved in, I mean, patients were in put in like half or quarter uh, uh, general anesthesia so that they can kind of feel things, but they're not fully awake. But we can ask them, hey, do you feel any better when we turn this on? Can you, feel that? We're going to crank it all the way up, and they can tell us in real time, oh yeah, that's the right spot. If not, you can drive it up a little higher, pull it back a little bit lower because you know exactly where it's at. So just kind of the outcomes are going to be, the future of this is just going to be better outcomes. Devices that don't necessarily need to be replaced, more higher durability and potentially just safer and easier to do. And what would I like to see? Gosh, I didn't think of that one. That's a great question. I'll get back to you. Dr. Hoopy.
You mentioned a few times, Taylor, that you don't like, that these devices, a lot of them, one part you don't like is they're not fixing the problem. So given kind of what statistics you gave about lead migration and things like that in a few of the studies, how are you kind of counseling patients and talking them through like these real risks versus, obviously hoping for functional benefit, but that we're not actually fixing the problem? How do you kind of address that with them?
Yeah, it's not an overnight thing, and as I went through the timeline of specifically the spinal cord stimulator, but any of the devices, there's a risk with anything. It just may not work. Excuse me. It may not work at all. It may not work to the to what we hope it will work. So counseling them and understanding that the benefits are, hey, you might feel some reduction in pain. Risks are you just might not. You understand that, and they have to go through that process. But none of these are just going to be a quick like, hey, do you want this trigger point injection today or not? Right? You can do that really easily. This is going to take weeks to months sometimes, and in that time, they have a couple of follow-ups with you, with other people, and so I just continually on follow-ups, continually reminding them of the problems, the risks that it just might not work, and continually, just keeping it at the forefront of their mind that they understand that this is a big procedure, especially this spinal cord stimulator. It's a big procedure. There's a lot of steps involved, and then at any point in time, you could just say, you know what, I no longer think you are appropriate for this. If they just are not understanding that it's not going to fix them, right? They're as a doctor, as one either consulting somebody else or pain management, anything like that, doing the actual procedure. At any point in time, you can just say, I just don't think this is appropriate anymore. That could be socioeconomic issues, psychosocial issues. A change in the actual characterization of their pain, or worsening if they have a spondylolisthesis that is grade 1 and then they get in an accident, now it's a grade 3 or 4. You probably don't want to be sticking anything in there without another surgeon doing something else. So roundabout way of saying it, it's a long process in general, and being able to talk them through each of those steps, just counseling them exactly what the literature says, and knowing that all these risks are there, and it ultimately is their decision to make the yes side of things, or the no. And then as a doctor, it's also necessary for us to understand that this does not, it's not a one size fits all procedure in general, especially for the spinal cord stimulator. I mean, it by itself, just the cost of it, I've heard is $80,000 to $100,000 through healthcare, and that right there can turn a lot of patients away if they don't have good coverage. It might not be the appropriate thing for them.
Yeah, I imagine you get very varied responses to when telling people they are appropriate or not after they've tried this, because I imagine if they've gone this far, their pain is quite bad and chronic.
Yeah.
Just a follow-up, do you guys work closely then with like VIP and psych to try to help these patients as much as possible, like, you know, like mentally deal with that aspect of it, like pre or post procedure?
Yeah, yeah, so we do have, or there are, at least in the circles that I run in here at VCU and the VA, yes, we have a direct connection with, multiple different specialties, like you said, psych, VIP, and Dr. Wells down at Stony Point and Dr. Rothman. They do the psych evals for the VCU side, and Dr. Wells actually has several patients who follow up with her for years on the psych side, simply because it's benefiting them to do that interdisciplinary even after they've received a spinal cord stimulator, because they realize that, oh yeah, this is something that's helpful in addition to the spinal cord stimulator. If that answered your question, yes, we do.
Yeah.
Work directly with them, or at least closely. Anyone on the Teams call have any questions? Look like it? Nothing in the chat? Okay. I don't know if that means I did a great job or not a great job. Thank you.
We'll do announcements real quick and then let everybody have a break before